Can we have Dr. Sujata?
Yes, I'll share my screen.
Yeah, yeah.
Good afternoon, everybody. At the outset, I would like to thank Dr. Chitra and the AIOS for inviting me to this very interesting debate. Dr. Brar has made my talk easier. He has actually accounted very nicely for the reasons why I would actually take a conservative approach. And just and I base my experience on two landmark studies, which Dr. Brar has already talked about, the infant aphakia treatment study and IOL under 2. The infant aphakia treatment was a randomized multicentric clinical trial from USA where they actually assessed IOL less than 7 months of age versus aphakia, and they found that the number of adverse events and additional procedures was way higher than the aphakic group. And IOL under 2 was also a prospective non-randomized study from UK, where they assessed 221 children, and they also found that IOL increased the odds of reoperation. And both of them recommended that in very small infants, we should leave these children aphakic. Now we come to the primary question, why do we implant IOLs? We expect a better outcome in children. We expect the glasses, as Dr. Brad was mentioning, to be thinner. Aphakic glasses are not good, he says, and we expect the glasses to be thinner. And of course, second surgery due to secondary IOLs will not be needed. Let us see if we meet these goals. Is the visual outcome actually better? The answer is no. Many studies have found that there are similar visual outcomes in aphakic as well as the pseudophakic eyes. But visual axis opacification is significantly higher in the IOL group across boards. It is as high as 45% in most studies. And in cases in countries like India, where we don't expect a very regular follow-up, visual axis opacification can cause a severe drop in vision. Now, are thick glasses really avoided? Well, in children, axial length calculation errors under general anesthesia is very common, and these are more when the axial length is less than 19. And we know the ones we, as pediatric cataract surgeons, we know how difficult sometimes it is to freeze these axial length when we have total cataracts in children. Again, keratometry errors are also higher in steep corneas, which is very common in children. And last but not the least, all the formulas that we use are all adult-based formula. And different studies have different formula, which they say has got least predictive errors. So there is no consensus on which IOL formula to use. And coming to myopic progression, that the lesser talked about, the better. It is highly unpredictable. In fact, 3 children in IATS needed IOL exchange because of the high myopic shift. So we really don't know whether this child may end up with a high hyperopia or a high myopic glasses even after we plan pseudophakia. Now for the third question, is the second surgery actually avoided? Well, again, the answer is no. Additional intraocular procedures were much higher in the pseudophakic groups, both in the IATS and in the IOL under 2 studies. And of course, we all know that the infants react much more. Inflammation risks are higher. And glaucoma is definitely more in immature angles, which is very prone to surgical trauma. And there are a host of conditions when we don't implant IOL. Corneal diameter less than 10.5, axial length less than 18, anterior segment dysgenesis, intraop, if your rexus is run off, you have high FEMA. So the cases need to be highly selective if you actually decide to do IOL in these small children. So to summarize, visual outcome remaining the same, so much gray areas in biometry, IOL formula, myopic shift. increased risk of visual axis opacification, second surgery, post-operative inflammation, and very limited cases which are ideal to put IOL. And last but not the least, the surgeon needs to be extremely proficient surgeon with a very nice, very good experience in pediatric cataract surgery. So if I have to err, I would err on the side of aphakia. I rest my case.
Thank you very much, Dr. Brar and Dr. Sujata. Dr. Sujata, I mean, your talks were wonderful and very clear.